But for some of our children's visits, obviously, we were able to get many of our members seen that wouldn't typically be seen. We had members with multiple children. So this really, I think, served as a viable option around scheduling for a lot of our families.
You know, you tend to assume, I think, that the broadband infrastructure is really well built. And what we've seen is, yes, that's the case, but in some of your lower income areas, their landlords may not have invested in really the infrastructure to make sure that their tenants can access broadband. And so we've made some intentional investments working with community partners to make sure that we're also addressing digital divide and access issues in urban areas as well.
I look at the utilization at our organization of our own telehealth solution that we put forth right during the pandemic. And I was delighted to see in our race and ethnicity data that there was sort of great uptake among African Americans, more so than in our white population or our Asian population. But then when you look at the language, more than 95% of the language in which the business was conducted was English. And so right off the bat, from working in New York City that means that we're leaving some people behind. And it's not so much of a digital divide as it is like the language plus digital.
We're really looking at it holistically. How do we create partnerships, referral mechanisms, and really data sharing pathways between all three of those groups, right? The health plan at the top with providers and CBOs on either side of that triangle. And so what we're looking at is value-based reimbursement mechanisms to really incentivize providers to make SDOH screening a standardized and routine part of the work that they do, and then share that information back with us, the health plan, so that we can holistically share that information across all of the providers an individual might see, as well as the community-based organizations that these members may go engage with on a regular basis.
It's really important that you really can't overscreen for the social determinants of health. I think there's really no such thing. There are so many barriers to people sharing that information with you. So I think first and foremost, we have it as part of our routine screener for our decent population. These become the kinds of questions that we routinely ask of people, just like we ask people, like, how are you feeling? Like, have you been coughing lately? Like, we should feel comfortable asking people and destigmatizing social determinants of health and making sure that we are routinely screening. In terms of using technology for it, we do think very intentionally about disease management. What are the conditions in which people, in particular in the conditions in which people live, that might contribute to that disease entity? Same thing for diabetes. People who come in and want to talk to us about like a digital solution around diabetes, that for us, that digital solution is not complete unless it asks about like access to fresh fruits and vegetables and has some way of, with some cultural sensitivity, being able to link people up to healthier food options, recognizing that those can, in some neighborhoods, can be prohibitively expensive unless you have like good strategies around that.
One of the big gap that's out there is providers are doing a great job screening for patient, but they are not billing for the Z codes, and obviously the policies and the reimbursements have not yet caught up into reimbursing providers for the great work that they're doing on that angle. So one of the great strategies out there is really partnering with your provider groups to capture some of that EMR extract data. Obviously, we tend to always focus on the quality data elements, but now there's more willingness from the provider groups to start to share this information.
We look at telehealth solutions or partner solutions that are digital when they say like, oh, our initial version is available in English only and it has no other language capabilities. For us, that's not the right solution, right? Like that is the kind of solution that would further create a digital divide. So I think some of it is just demanding more out of all of the ecosystem players to say it is our collective responsibility to make sure that our products are designed to reach the most vulnerable. I think telehealth can be helpful in terms of reducing the barriers to access and making it convenient and available, so long as it doesn't continue to replicate some of our limitations of our, brick and mortar, like we're only open 9 to 5 Monday through Friday, right? Like that is, we know that that's a model that doesn't work for it doesn't work for anybody, frankly. It doesn't work for me, but it doesn't work for, like, especially for vulnerable populations who may need more flexibility in terms of being able to access, nights and weekend hours.
So telehealth, I really view as a tool in the toolbox, right? And if you really want to improve healthcare and outcomes for the most vulnerable, for those that are traditionally underserved, you really have to meet them where they are. And you can't do that unless you really take the time. Data analytics is a piece of it, but you've really got to take the time to understand what the needs are for that population, what their specific barriers are.
So somebody that has multiple chronic condition that's struggling with the social, but that's also struggling with keeping up with their medication. It's hard to tackle all of that in a telehealth visit, right? So I think part of the, what I'm hoping to see the industry starts to head towards is more guidance around these sorts of visit for this profile is appropriate versus this one may be more appropriate, especially if we have a history of SDOH and so forth.
I think our legislators need to update and upgrade our regulations. Many of our regulations were written in the 90s across the country, so they have not adapted to the new individual. We look very different than what our health looked like in the 90s. Traditional health insurance no longer works. I think that we need to look at reimbursing the services that are needed as opposed to some of the really outdated terms of medical necessity that drives payment. I think that we need to really look at expanding what is offered, really expanding the scope of what health plans can offer, because again, we're treating the whole individual, not just their illness.
So I think there's a lot more to learn about how we kind of go from fully remote back into this hybrid world. What should be what should be face to face, what can be done via like telehealth, and also to understand what's best to do. So there are some things that you can do over telehealth that are still suboptimal compared to their face to face, and vice versa. There are some things that are much better done through telehealth than they are in person. And I think really sorting that out once and for all, and understanding that that actually might not be such an easy, like, put it in pile A here, pile B here. That might differ like by age, it might differ by condition. There's gonna be a lot of nuances here.
Starting next year, we'll start to report out very specific race and ethnicity by metrics. Right. So now we would be able to be held accountable to African-American A1C control, right? Things like that. So I think the industry in itself needs to start to hold each other more accountable and start to think about how do we hire a more diverse workforce to be able to support a lot of the things that we are seeing in the community.